It's great to see everyone here. As you know, every time I introduce this series, when I first arrived, Monica and I really sort of thought, hey, we're bringing really great researchers, really great scholars, teachers, practitioners here to Stony Brook, but we have so many amazing people here at Stony Brook, and we've not created a platform for them, or at least at that moment we didn't have one. So that's where this idea of having our distinguished professors present to all of us within our community, and to try to have two individuals who maybe at the surface might seem that their work intersects not so much, but when you really think about it, there's so many of these connective threads. And that's one of the things that I love about this event, is not just the quality of the scholarship, but seeing those connective threads, because that's what community is. And so I thank you all for being here. This is also about, I said community, but also about excellence. And if you think about the fact that there's 560 distinguished faculty across the SUNY system, and there's 63, 64, 65 campuses, and Stony Brook has a quarter of the distinguished faculty. It's very impressive. And speaking of impressive, today we get to hear from two of those distinguished faculty. Patricia Coyle, SUNY Distinguished Service Professor in the Department of Neurology in Renaissance School of Medicine, and Joe Mitchell, SUNY Distinguished Professor and Chair of the Department of Applied Mathematics and Statistics in the College of Engineering and Applied Sciences. So to start, I'm pleased now to introduce another Patricia, Patricia Melville, who will introduce Patricia Coyle. Patricia Melville is also a Stony Brook neurologist. She works closely with Dr. Coyle at Stony Brook's Multiple Sclerosis Comprehensive Care Center. The pair have worked together for more than 30 years. And when you think about partnerships and what that means to scholarship and what that means and what we can accomplish together, they are such a great example of that. In fact, Patricia counts Dr. Coyle as one of her mentors, which is a testament to the power of service and mentoring. With Dr. Coyle's support, Patricia became an adult nurse practitioner and has been actively involved in MS research, including industry-sponsored clinical trials and investigator-initiated studies. She's on the board of the International Organization of MS Nurses, a past president of the Long Island MS Nurses Society, and the author of numerous peer-reviewed journal articles. Together with the other researchers and healthcare professionals at the Stony Brook MS Comprehensive Care Unit, the two Patricias have helped us better understand, manage, and treat this complex and debilitating disease. Patricia, thank you for being here to introduce Dr. Coyle.
Thank you very much. That was a lovely introduction. One correction, I am not a neurologist. I actually am a nurse practitioner, so I just want to make that clear. Good afternoon. It is my very great pleasure today to introduce Patricia Coyle, Distinguished Professor of Neurology, Vice Chair for Academic Affairs, and Director of the Stony Brook MS Comprehensive Care Center at Stony Brook University. A little bit background on Dr. Coyle. Dr. Coyle received her medical degree from Johns Hopkins University School of Medicine, where she completed her neurology residency, served as chief resident, and pursued advanced fellowship training in neuroimmunology and neurovirology. She's internationally recognized for her expertise in multiple sclerosis, neuroimmunology, and neurologic infectious disease. Dr. Coyle has helped shape the standards of MS care through leadership roles with the American Academy of Neurology, the American Neurological Association, and the American Board of Psychiatry and Neurology, and the National MS Society. She's also served as an advisor to the U.S. Food and Drug Administration and the Institute of Medicine. I've had the privilege of working alongside Dr. Coyle for over 30 years. We both were teenagers when we started, and can personally attest not only to her extraordinary scholarship and leadership, but also to her unwavering commitment to patients and colleagues. A recipient of NIH and National MS Society research funding, Dr. Coyle's work continues to advance our understanding of MS pathogenesis while improving the lives of patients and families living with this devastating disease. Please join me in welcoming Dr. Patricia Coyle.
So I'm going to be talking about the puzzle of MS, which is a disease that I've been interested in for very many years. I think it's a fascinating disease. These are my disclosures. I became interested in MS as a medical student, resident, and fellow in Baltimore. And I think I got involved in research from the point of view of looking for myelin targets in the spinal fluid and studying how an infection might cause demyelinating diseases. But I think what really got to me was I got a chance to rotate through the MS Center, and I was sitting across the table from people my age, and I was telling them they had a neurological disease that was untreatable. It's like hearing you have cancer, but there's no treatment for your cancer. We weren't going to be able to cure their MS. We didn't have a treatment for it, and it was completely unpredictable. So you didn't know, sort of sitting under the sword of Damocles, whether the MS would strike at any time. You'd have a mild course or you'd have a very good course. And if you had asked me back then what causes MS, I'd say we don't know, but it's genetics, environment, and the immune system. And if you ask me today what causes MS, I'd say the exact same thing. But we filled in the puzzle very greatly. It's much different now. We have much better ideas about MS, and we're slowly grinding to complete that puzzle and understand this disease. So I'm going to talk about what makes MS unique, the perspective from 1992 to 30 plus years later, 2026. What are the recent novel insights about this disease? What are the gaps, and what is the future? So interestingly enough, we have a patron saint of MS, Saint Lidwina. She was born in 1380 in the Netherlands, and I mention her because she's frequently put in the literature as probably the first example of a patient with MS, many years before it was recognized as MS. She had trauma at age 15 or 16, and then went on to a progressive neurological disease, patron saint of chronic illness, of ice skaters apparently, and MS. Robert Carswell was a Scottish pathologist who actually showed pictures in his atlas of an MS case. He didn't realize what it was, but that was the first example showing MS. And then, of course, Charcot was pivotal in his series of lectures in defining MS as disseminated sclerotic plaques within the central nervous system. And you can look at an autopsy study and see the changes of MS. Now, this is a very unique and puzzling disease. First of all, it hits young people. When you think about neurologic diseases, stroke is age-related. The dementia syndromes are age-related. Parkinson's is age-related. ALS is age-related. You don't have very many diseases that strike young people. 90% of MS appears between the ages of 15 and 50. It's unusual under age 11, that's less than 1%. It's unusual in a very late onset over age 60, that may be 1% or less. But young people, as they're starting families, starting careers, those are the choice targets of MS, classically young women of childbearing age. This is a highly variable disease. There's no cookie cutter stereotypic. ALS, you know the average lifespan is 3 years. Parkinson's, downhill. Dementia's the same thing. Not true of MS. You can have very mild disease. You may do extremely well. You can even have silent MS, or you can have very severe disease that will cripple the person within 6 months, a year, or anything in between. Why is that? Why is MS so variable? That's really an elusive question. Now, originally, this was not dispensed over the globe equally. There are low, medium, and high-risk zones. Why was that? That's a sort of pattern you see with an infection. Now the globalization of the world has really blocked that to a certain extent. So in the United States, for example, we no longer have a north-south gradient. But initially, there was very little MS at the equator. It increased as you moved away from the equator. And where you spent your first 15 years were critical. You kept that risk. If you grew up in an area up to age 15, you kept the risk, even if you moved to a higher risk or lower risk area. Now, that's no longer so true, again, with the globalization. But how do we explain that with MS? Isn't that peculiar? There's a 3-to-1 female ratio, and that seems to be increasing. That's not enormous. Lupus is 9-to-1. Neuromyelitis optica spectrum disease is a 9-to-1 female to male predominance. But 3-to-1 going up, young people, obviously you have to pay attention to that. And again, the etiology is not pinpointed, although we pursue genetics, environmental factors, and the immune system. And key are 2 recognized courses. The most common form of MS is relapsing disease with acute attack, flare-ups, relapses, like an optic neuritis, loss of vision in the optic nerve, like a transverse myelitis, or an inflammatory attack on the spinal cord. That's how 85 to 90% of MS presents, with attacking disease. Not abrupt attack, not stroke, not sudden onset, not less than 4 hours, but coming on over a couple of days, a week or so, and then getting better over the next couple of weeks. That's 85 to 90%. The other form of MS is progressive MS. That's slow deterioration, classically hitting walking, ambulation, and gait, particularly seeming to target the spinal cord. And you can be progressive from onset, primary progressive, or you can convert from relapsing disease to progressive disease. That's bad news. Once you're progressive, you are going to become disabled, we believe. And you can't really stop that progression, and we don't have as good treatments for progressive MS. So if we look at 1992, that was the last year we had no disease-modifying therapies for MS. Imagine in our lifetime, in the last 30 years or so, we've seen a transformation of MS. We've changed the natural history of this disease with our disease-modifying therapies. So in 1992, we not only had no cure for the disease, we had no treatment for the disease. MS is a huge success story in neurology, in the neurosciences, because of the development of valid, meaningful disease-modifying therapies that decrease damage from the disease to the target body organ, the central nervous system. And we have changed the face of MS. When we go back to pre-treatment era, pre-DMT treatment, what was the future of MS? And you can think of a wheelchair. So you would have such profound dysfunction in being able to walk that you were going to wind up wheelchair-bound. Of course, as you continue to damage your central nervous system, the major organ of the body, I believe, you're going to get cognitive issues. You'll lose the ability to have a job or a vocation, or it's going to interfere with that. And the vast majority of individuals in that era ultimately became disabled, They used clinical descriptors to say the first attack was a clinically isolated syndrome, then you have relapsing MS, then you have progressive from onset, primary progressive MS, and you have a relapsing patient that may transition at midlife to a progressive stage of MS, secondary progressive. These are clinical descriptors, not biological descriptors, and people are more interested in biological descriptors now. Fast forward to 2026, 10 distinct mechanisms of action over the disease-modifying therapy group. If you count the biosimilars and the generics, there are over 20 different products, all approved to treat relapsing MS. One of them approved to treat progressive from onset MS. That's a humanized anti-CD20 because they had a positive phase 3 trial. It's hard to get positive phase 3 trials in progressive MS. We have multiple treatments now for relapsing MS with heavy use of the anti-CD20s, the B-cell lytic agents that drive B cells down to 0 levels in the blood compartment, that is a great treatment for relapsing MS. It happens to be an anti-CD20. That's the only approved drug for progressive from onset MS. It's not such a great treatment, to be candid. It slows progression, but it doesn't work very well. So we have good treatments for relapsing MS, great treatments for relapsing MS, but not so much for progressive from onset MS. And that's why there's a focus now on getting treatments for progressive MS and getting CNS repair strategies to fix acute deficits faster, to fix long-standing deficits ultimately. And there are very many things being done in that regard, but we don't have a meaningful central nervous system treatment yet. So what are some novel insights in recent years and months that have come about in understanding MS? That this is a homogeneous disease continuum, that we need biological descriptors of it, not clinical descriptors of it. That we have a silent MS stage, radiologically isolated syndrome, or RIS, is a patient who happens to get an MRI scan, and maybe they were participating as a healthy control, or maybe they had a headache, or maybe they had a concussion. You get a lot of imaging in those sorts of settings. And lo and behold, their MRI scan is abnormal and it looks like MS. There are multiple lesions. There's no story for MS. There's no exam for MS. This is radiologically isolated syndrome. And in the global database, followed 15 years, 72% presented with either relapsing or primary progressive MS. Not 100%, but 72% in a 15-year follow-up. And then we now realize there's a prodromal state to MS. This is a state where there's something going on health-wise for 5, 10, even 15 years before they present with the first neurological features of their MS. That prodrome is fascinating. We don't have a way to identify these patients yet. We also know that CNS inflammation is present at all time points in MS and is extremely important because there are two different types of CNS inflammation that we'll talk about. We have revised diagnostic criteria. They've been revised several times. The latest revision is the 2024 revised McDonald diagnostic criteria. It was only published in late 2025, by the way. But that does a lot of things, and I would say if you go to an office concerned with MS and you say, do I meet the criteria for MS, the diagnostic criteria, if the doctor doesn't know, you should run away, get another office, get another office. What did that diagnostic criteria, the revised, do? You can now make a diagnosis of MS in silent MS, radiologically isolated syndrome. So you can diagnose somebody with MS despite their never having any clinical features of the MS by the new diagnostic criteria. They've added optic neuritis as a critical dissemination in space site joining cortical, subcortical, periventricular, infratentorial, and spinal cord. They give 2 new MRI diagnostic biomarkers, the 6-vein central vein sign, the 6-vessel central vein sign, which hopefully will come to clinical use pretty quickly now that it's been endorsed as a way to help diagnose MS. And the other one are so-called phase rim lesions, or pearls, where you see an expanding lesion in the brain that is not contrast enhancing. It hasn't focally breached the blood-brain barrier, that has no activity in the center, but has an active expanding rim of activated microglia and monocytes. And in the case of the phase rim lesions, the pearls, they phagocytized iron. That's causing oxidative stress. That's a damage mechanism. These pearls and expanding lesions are biomarkers for MS as opposed to other diseases. And then they have a new spinal fluid immune marker. It's likely to replace CSF-specific oligoclonal bands. It's kappa-free light chain index. And why would that replace oligoclonal bands? Because it's as sensitive, it's cheaper, it's faster, it's totally automated. You need no human input to judge the bands as you do in oligoclonal bands. So that will likely happen. And that's just part of what the new diagnostic criteria do. We now know that progression is believed to be a single process. What does that mean? that progression in primary progressive from onset, progression in secondary progressive is the identical process. It's the identical pathology. It's not different pathology. This would be a basis for putting relapsing and progressive patients into the same therapeutic trial. It would also mean that if you established a treatment for primary progressive, it should help secondary progressive and vice versa. And we'll move to the inflammatory neuropathologies. And this is, I think, a seminal observation. The current thinking is that in MS, we have two distinct CNS inflammatory pathologies, and virtually everybody with MS has both from very early time point. The first is acute focal inflammation that underlies the relapsing component of MS. These are blood lymphocytes, blood immune cells that penetrate the barrier, crossing small veins, and cause perilesional demyelinization. This is the systemic immune system, the adaptive immune system. It explains why a number of our disease-modifying therapies don't penetrate the CNS and yet are very successful in treating relapsing MS. Signs of this focal inflammatory relapsing component are clinical attacks, relapses, okay? In addition, contrast-enhancing lesions, a focal breach of the blood-brain barrier, gadolinium enhancement is positive in that lesion. It allows the lesion to be dated. It's currently active. That's active relapsing disease. And then macroscopic lesions. Those are the signatures of this focal inflammatory relapsing phase. And understand the frequency of this falls over time. It reduces with time. It reduces with duration of MS to the point that we believe in many individuals who have just this relapsing component clinically showing up, you may be able to come off your treatment for relapsing MS once you get old enough if you have not converted to a progressive form. The second type of inflammation underlies progressive MS. It's smoldering inflammation within the CNS with activated microglia, maybe toxic astrocytes, and various immune cells. This also underlies PIRA, P-I-R-A, progression independent of relapse activity. That's what a progressive MS patient shows. It's not a relapse that's causing the worsening. It's this progression with smoldering inflammation and neurodegeneration. Damage to synapses, axon neurons is most marked in progressive MS, and you can see that in some of the special lesions. This also has an age impact, but I think the novel concept is that this is present very early. It's not late, it's not following. The progressive MS clinically often presents at age 45 to 55, but that's not because that's when you're seeing the CNS inflammation, the intra-CNS inflammation, the innate immune response. We think that that's ongoing much earlier, but you pass a reserve point where you now see the clinical counterpart of that smoldering inflammation, gradual deterioration of progressive MS. So you have two distinct CNS inflammations that underlie relapsing MS, and the other underlies progressive MS. And virtually every MS patient has both. What causes one to dominate over the other, we don't know, but hopefully we'll be able to figure that out. And the continuum. We think that you have to be genetically at risk for MS. That would be about 7.3% of the population. We don't know that for sure, but we think that's correct. You're not born with MS. MS starts at puberty, post-puberty, in the teens and 20s. So something happens about that time that unleashes MS, that allows it to happen. MS in its variability can be silent. In fact, in limited autopsy data, they project that 20 to 25% of people that pathologically have MS may never show any expression of it. That would be a very high rate, surprisingly high, but we're capturing that in part with radiologically isolated syndrome. So that would be asymptomatic MS. What about the prodrome? This is based on huge numbers of databases of healthy controls and huge numbers of MS databases. And what they found is the following. Like other neurodegenerative diseases, if you look at the time frame in years before the presentation of their MS, and you compare them to matched controls in huge numbers, the use of the healthcare system is significantly greater in those destined to have MS. Their prescriptions and visits to the doctor, to the hospital, are significantly more than matched controls. There's something going on in that prodrome that has announced that they're going to be developing MS, and there begins to be damage to the central nervous system. Now, these statistics of what the prodrome looks like are too nonspecific at the current time to be able to cull people out and figure that out. But wouldn't it be amazing if we could really define an MS prodrome and find people who are destined to develop MS before they're showing any significant damage signs of it, and what could we do about that? And then, of course, there's relapsing and progressive MS. So the etiology, we don't know. Genetics accounts for an important part, but not a huge part. They've identified 233 risk susceptibility genes. They deal with inflammation in the immune system. They're starting to develop disease severity genes. They seem to relate to the nervous system. So it's a completely different relationship. So there is a genetic input, but it's clearly not a genetic disease. You don't inherit, there's no gene that gives you MS. Then there's the environment. And the major environmental factor is infection with Epstein-Barr virus. 32-fold increase of MS. Now you can have adolescent obesity and smoking and vitamin D deficiency, at least in Caucasians. But this issue with EBV is very interesting. It has been said that there's not an adult onset patient who's not EBV seropositive. That statement has been made. Now, at a very recent meeting, in fact, last week in San Diego of MS, they presented an Ontario database where they pulled out people from their very large series that had tests that showed that they had just developed infectious mono. And the major cause of mono is EBV. It's not the only cause, but it's the major cause. They had evidence of an immune response to EBV that seemed to be their naive first approach to EBV. And then they tracked down how many of these people had MS, 300. And then they looked at how many people had signs of MS before they had the positive serology for EBV. And it was about 42 cases, dozens of cases. Now, this has not been peer-reviewed, it's not published yet, but we really need to resolve this issue of whether EBV is required to develop MS or not. We know there's not active ongoing damage, or we think there's not active ongoing damage from EBV, but there's an integral relationship. There are a lot of cross-reactivities between the nervous system and EBV and the immune system and EBV. It causes a latent infection of B cells, an active infection of epidermal cells. So this is an interesting question because people are calling for considering promoting vaccines to prevent EBV, because could that possibly cure MS? I don't think so if this Ontario study is correct. How does MS get worse? One is age. And think about biologic versus chronologic age. So that's our birthday for chronologic age. It turns out if you look at various biologic methods, the MS patient is old. The MS patient is old. They have clear increased biologic age compared to the chronologic age. You can damage CNS reserve. That's probably very important. If you allow a lot of lesions that have hit the brain and the spinal cord, and then you start the descendancy in your late 30s, and after age 60, you have 0.5% of the brain shrinking in everybody. That's healthy controls. You know you're on the downswing there, and you've really hurt CNS reserve, so you don't want to do that. You want to make sure you identify comorbid conditions, have the right lifestyle choices and wellness program. And for progressive MS, they're looking at damage mechanisms, which are important. Neurodegeneration, smoldering inflammation, glial toxicity, oxidative stress, mitochondrial dysfunction, energetic failures, glutamate. These are all evidence damage mechanisms in progressive MS. The problem is we don't know, do we have meaningful subsets of patients, or do some have more damage than others in specific areas? We need to determine that. Gaps, we don't know the etiology of MS. We can't cure the disease. We need better treatment for progressive MS. We need CNS repair strategies. Can we stop an MSDNT after a certain age? And what is the role of aging in MS if everybody with MS seems to have biologically aging beyond their chronological age? And can we clarify the role of EBV? So we have personalized medicine for MS. We don't have precision medicine yet. Hopefully that's coming the way they do in the field of cancer. We need successful biomarkers, digital monitoring, home tracking devices, and artificial intelligence, machine learning. And these will be my last slides. Using AI, you can show that the biological age of MS is greater than matched controls and is actually a prediction for MS doing worse. This was a recent study using the Novartis Oxford database that had over 8,000 MS subjects followed up to 15 years, phase 2 and phase 3 trials, greater than 35,000 MRIs. They asked the computer to biologically explain MS. How would they explain MS based on the analysis of this data? They found 4 dimensions to consider. One is physical disability. The other was new brain damage, MRI lesion burden, T2 lesion burden, and volume loss, clinical relapses, and new asymptomatic disease activity, meaning contrast-enhancing lesions. They found 8 disease states. States 1, 2, and 3 were pretty mild MS. State 4 was asymptomatic MRI activity, contrast-enhancing lesions. State 5 was clinical attacks, and then states 6, 7, and 8 were severe MS. What they found was you never went from the mild stages, 1 to 3, to stages 6 to 8, the bad MS. You had to go through the relapse phase or the silent MRI lesion phase. And each visit to those inflammatory phases increased the risk of going on to advanced MS. And once you reached advanced MS, you did not come back. And they found no distinction between PPMS and SPMS. So the message this sends to me is to hit MS hard, hit it early, don't allow any inflammatory diseases. And I think we'll see completion of this puzzle in the next few years. Thank you.
That was really quite lovely. I was at CETUS Chiron in 1992 and saw the first beta interferon studies basically showing a diminution of MS progression in patients. So Biogen basically developed the drug, but CETUS Chiron developed the beta interferon that was used at that time. So I've been following MS somewhat over the last 40 years, bits and pieces, and my studies basically at the time, I was in biotech and worked at DNEX and did a lot of work in immunological interferons. So what I find really fascinating is the recent studies that just showed that EBV is in a continuum in lupus, and that there are other autoimmune diseases in which Epstein-Barr virus is highly correlated with potential etiologies. The data in MS, basically from the million patient studies that basically are mathematically showing probable causality, make me really wonder if in EBV studies, if an antibody basically, or antibodies trials basically couldn't somewhat be prophylactic or therapeutic a la shingles, and that the development of an antibody or antibodies, basically whether it is in MS or potentially other autoimmune diseases, which it's again highly correlated with as in lupus, would not basically provide more definitive demonstration of the ability of modalities that could inhibit EBV, should those not basically be a really strong focal effort of this community?
So the EBV issue has two major questions. One is, if you got rid of EBV infection, would you get rid of MS? Now, the Ontario data that I just mentioned there would speak against that a little bit. The second is that there are increasing studies that indicate that once you're infected with EBV, you're infected for life, but you're seeing immune abnormalities, and the issue is that helping to drive a damage mechanism in MS? Thus far, the studies that looked at cytotoxic SD T cells against EBV, they failed. They failed. But this has to be resolved. We have to understand the role that EBV is playing.
You have a brain barrier, which is part of the issue.
Yes.
I mean, so you have cells that have now entered into the brain. So to me, it's a continuum question as to, can you basically modulate, maybe not 100%, but basically by diminishing the role of the T cells, the B cells, which is what you're doing with your anti-CD20. Right. Basically, it may not be a cure-all, but it may be a mechanism for diminution. And if the virus is not basically present or as highly present, whether, again, this might not diminish the overall infection or the ups and downs thereof.
Well, it clearly needs to be resolved, that's for sure, to see what the role of treating EBV. And I should just make the point, I spoke too long, but patients faced a wheelchair in the pre-treatment era. Now when I start an effective agent in early relapsing MS, I'm telling them, I believe you can live a normal life. You're gonna live a normal life, you're gonna get through this. And it makes a difference. We've changed the natural history of this disease. People walking around with MS you would never imagine had MS.
Thank you for the lecture. I have a question regarding machine learning. You mentioned at the end
Yes.
it has been used for answering various questions, but my question is related to understanding what causes MS at the deepest level. Machine learning has made lots of progress also in revealing causalities. What is the state of the art in that domain?
So you are starting to see AI used in neurology. For example, the data that I showed you, that hasn't been duplicated by anybody else. It hasn't been accepted, et cetera. But it was an example of using the computer to stratify MS and do they make meaningful observations. And it kind of makes sense when they talk about shutting down the damage process. Indirectly in treating MS patients, it seems like using high efficacy, the earlier you use it, the better in avoiding late disability. That seems to be the message. We definitely need progressive MS treatments. Right now, there's a lot of talk about BTK inhibitors, oral BTK inhibitors. None are approved for MS, but there are at least 6 that have gone into studies in MS with at least 2 positive phase 3 trials in progressive MS. These BTK inhibitors that they've designed to test in MS enter the CNS and would target microglia as well as B cells. So I think it's a very exciting time, and on the horizon there are success stories in progressive MS that we'll be able to use. The issue will be how early to institute it. If the changes are being set very early in the disease, would you use it in somebody even though they didn't show signs of progression, for example? These are some of the dilemmas that will be coming up.
Thank you so much.
We're starting to see AI used for multiple reasons. With a preliminary study, I pulled out 2 that looked at, classification and aging of MS.
Thank you so much, Dr. Coyle. And can we give Dr. Coyle another round of applause?